Please welcome to the stage, Wayne Glasgow.
Good afternoon. I'm Wayne Glasgow. I'm the Senior Vice Provost for Research at Mercer University. Mercer's been a long-standing sponsor of Health Connect South, and we are strong supporters of its mission to foster and highlight partnerships and collaborations. It's my privilege today to introduce our keynote speakers. The background of these speakers reflect well the variety of healthcare perspectives that are here today, as they've been involved as practicing physicians in academic medicine and media, and also as elected and appointed healthcare government leaders. Dr. Mehmet Oz currently serves as the 17th administrator of the Centers for Medicare and Medicaid Services. Dr. Oz has won 9 Daytime Emmy Awards for The Dr. Oz Show while hosting this show for 13 years. He's Professor Emeritus at Columbia University and led the Heart Institute at New York Presbyterian Medical Center with research interests including heart replacement surgery, minimally invasive surgery, complementary medicine, and healthcare policy. He's received numerous patents and authored over 400 original publications, book chapters, and medical books, also authored 8 New York Times bestsellers. He received his undergraduate degree from Harvard University and obtained a joint MD and MBA from the University of Pennsylvania School of Medicine and the Wharton School of Business. In 2003, Dr. Oz founded HealthCore, which places recent college graduates into high schools around the country to teach diet, fitness, and mental resilience. He's raised over $80 million to help nearly 3 million teens with this nationwide program. Also, one of our keynote speakers is Dr. Tom Price, recently served as the 23rd Secretary of Health and Human Services. Dr. Price received his bachelor and MD degrees from the University of Michigan and completed his orthopedic surgery residency here at Emory University. After his training, Dr. Price began a medical practice in Atlanta, which would eventually grow to be one of the largest non-academic orthopedic practices in the country. He also served as the medical director of the orthopedic clinic at Grady Memorial Hospital, as well as an assistant professor at Emory University School of Medicine. Dr. Price ran for public office and was elected to 4 terms in the Georgia State Senate, during which time he was chosen by colleagues to serve as the Senate Minority Whip and later as the first Republican Senate Majority Leader in the history of Georgia. Dr. Price also served as the U.S. Representative for Georgia's 6th Congressional District, and he held this office from 2005 to 2017. He served in various leadership roles in Congress, including chairman of the House Budget Committee. He currently is a board member for a number of entities in the private and nonprofit arenas and as a consultant or advisor to numerous companies. Please join me this afternoon in welcoming Dr. Oz and Dr. Price as our keynote speakers.
Thank you. Thanks so much, Wayne. Sure. God bless. Hope the lunch was good.
Afternoon.
So I was just telling Dr. Price, Secretary Price, that Oprah always sat on this side.
So here I am.
The shoes were always too high or too low, and the stage door was there. So she trained all of us to sit on this side. Well, as guests, you sit here, but when we hosted our own shows, the people who graduated from the School of Oprah, we sat here. So now you get to be the host.
Good. Thank you so much. Have a seat. Welcome, welcome. Have you ever had an audience that included whales?
No, my gosh.
Yeah, beluga whales.
Are those sharks in there? Oh, look at that. Kidding, just kidding. Pandemonium at the
Thanks
aquarium.
so much for joining us today, Oz. It is great to have you with us and welcome. And it's almost a welcome back, I think, because your dad, I believe, did his cardiothoracic surgery residency at Emory when you were young.
My first 2 years of life were spent in Atlanta. The sister one below me was born here, and my dad had trained, and this is actually an important observation. My dad had trained in Turkey at the end of the Second World War, which America realized may have been the best medical training you could get in the world, because all the Jewish doctors had been chased out of Central Europe by the Nazis. So they recruited heavily out of his class. He was brought to this country, ended up training here, living here for a good part of his adult life. Ultimately, my mom dragged him back to Turkey, but I had wonderful that my sister was always called the Georgia Peach.
Yeah. Well, welcome home.
Thank you.
Welcome
it's
home.
still peach season, right?
Yeah, absolutely.
Good. Making sure. That's why I came.
He's a Phillies fan, so we're going to forgive him for that. So, but sincerely, thank you so much for taking this position at a very pivotal time and consequential in a public role, and it's a challenge right now for public roles, obviously. You've been at CMS now about 5 months. Can you share with us what your biggest surprise was and maybe your top 2 or 3 priorities?
Biggest surprise for me is pretty straightforward. How many of you have seen the movie Zootopia? You remember the sloth at the DMV? I say this sincerely. I think if a lot of Americans think that's what the federal government is. And it's just not. You have incredibly talented people, superstars, who left often, usually higher paying private sector jobs, come into government. They want to make a difference.
Yes.
They feel mission aligned. What they don't like is to sit around doing nothing. And so if you can give them ideas, or allow, more importantly, their ideas and the people who work for them ideas, because usually the best ideas are 2 or 3 levels down in an organization, and let those bubble to the top and run with those, then you can actually get folks who are already fantastically capable to actually perform. And we created OKRs, Objectives and Key Results, which are usually used in technology companies. All major companies seem to have some form. We created ones at CMS. We're very much aligned with them. We'll talk about some of them today, but the first one, the most important one to me, is the team. The most valuable thing I could ever do in this job, and you may have felt the same way when you're serving as secretary, is to hire the best people in America to work in healthcare at CMS, and then make sure they don't kill each other. Right? You got to do both, because capable people tend to have sharp elbows sometimes. But that part I'm thrilled by, and we are recruiting actively. If any of you are looking at ways of changing the world, please think about it. I used a line which I'll share with you, because the main reason I came here is to announce we're open for business. We're open for business because we want interconnectivity. We're going to talk about the digital transformation that's happening in America and how we're going to hopefully catalyze that. But it's going to take place in the private sector with us building safe guardrails around it. We want you to do what you're doing or come work with us. But the people that I was privileged to recruit, like Steph Carlton, Chris Klump, and Chris Klump built a $1 billion business called Collective, and he sold it to come work in us. And my argument was, if you made a $1 billion business, you can save us $100 billion. Of course. But the other thing I kept saying to folks, and it might resonate with some of you, is if you don't come, you're going to regret it for the rest of your life.
Exactly right.
And the reason is, if you come and we succeed, you'll have changed the world and you'll know it. But if you don't come and we succeed, you'll have missed out on a life-changing opportunity. And equally possible in your mind, if we fail and you didn't come, then you have to blame yourself. And so one way or the other, you can't stand on the sideline anymore. That's right. And I think that's sort of the big message for Health Connect South. You got to get in the game in one way or the other. And this is a really good time to do it, because there's a tremendous amount of focus on the areas that you're already engaged in. And this government wants to hear feedback. And I know we're going to talk about some of the details.
Yep. Yeah, exactly. Well, one of the things that I was so impressed with was the 80,000 employees that were at HHS writ large all around the world, and the quality of the individuals, many of them subject matter experts for the world in the area. There's about a $4 or $5 trillion question, though, out there, and that is the cost in healthcare. We spend over $15,000 for every man, woman, and child in the country on healthcare. How do we control that cost without compromising quality or safety for patients?
Well, those issues are closely aligned to me. The most expensive thing in medicine, which every doctor, nurse, practitioner will acknowledge, is bad care, right? Orthopedics. I come to you for hip replacement, or more likely someone else does hip replacement poorly, right? So you're paying someone to do a bad job. Then you're paying someone to do a good job to fix the bad job, and they're often highly skilled, so you got to pay them fairly, and then you got to pay for the complications that ensue. And so if you get it right the first time, we save ourselves a lot of money. Part of the challenge is we have not included the person with literally the most skin in the game, the patient. They're almost an afterthought. They're left to the side to fend for themselves to find the best care that they might think is for them. Is it the right doctor? Does this medication make sense? Or is it the one they saw on television? Who are the people they're going to trust with advice? Are they going to be motivated to do the things that make a difference? And this is especially important in vulnerable populations. And when you walk into the Humphreys building, that both of us have worked in, there's that quote on the left from Hubert Humphrey about the moral test of government being the management or care of people at the dawn of their life, children, at the twilight of their life, seniors, and as you remember, hauntingly, Hubert Humphrey said, in the shadows of their life. If you're a Medicaid patient, the chance of your canceling a doctor's appointment in many of the clinics that I visited is twice as high as a Medicare patient. You can't get off from work. You fear you're going to lose your job if you do. You don't have a car or transportation. You're overwhelmed. You forgot. There's always obstacles. They just seem bigger in a population that desperately needs the care. And so if we could actually empower patients, and I think many of you have tools that could help with that, then the digital technological transformation we're talking about starts to blossom. And I'll leave you with one thought here, because it's not just about getting doctors to do our jobs better. We're going to get to that, and I think it's important. But I would argue, and I've been told this by folks I trust, the number one driver of cost, really, is loneliness. Why? Because if you're by yourself, you don't have anyone else to do quality control for you. So dual eligible populations from Medicare, Medicaid, poor old people who don't have a lot of support around them, they're scared. So they're going to default to the emergency room if they don't feel well. Or they're not going to treat a problem that could have been addressed in a timely fashion, and they end up in the ICU for 3 months. So all these are issues we can start to get into if I can just be with you where you are, which is literally in your phone for a lot of folks. And don't think older people don't have phones or Medicaid patients don't have phones. 91% of Medicaid patients have a smartphone. 91%. And we could unlock that and reap benefits by incentivizing people just to use the tools that we're giving to them to prevent them from making mistakes, rookie errors, so to speak, because we're all rookies when it comes to our own health, that land them in the hospital and cost the system a lot of money.
Exactly. Here in Georgia, as you likely know, we've implemented a program called Georgia Pathways, which was implemented in the first Trump administration. It allows individuals who are either working or volunteering or caregiving, serving as a caregiver for somebody in their family, to access Medicaid if their income level is correct. Can you talk a little bit about yours and President Trump's vision for Medicaid and work requirements vis-a-vis that?
So I know a lot about the Georgia program. It's actually known widely around the country because it's I think a very smart path for states who are not expanding Medicaid. And it might be a path for states that have expanded who want to go back. And it's a clever and thoughtful and customized approach. Let me take a step back, though, and talk about Medicaid in general. So 60 years ago, this year, Medicaid was created with Medicare. When it was created, it had 11 million people in it. It was designed for the people Hubert Humphrey identified that I mentioned earlier. There was no concept at all of able-bodied people being on Medicaid. The thought of free care and how to offer it, very different proposal to the hospitals and the healthcare system, all that's obviously changed. So what the president wanted to do, and he said this over and over again, and to me personally, when there weren't a lot of cameras around, he said, I want you to just take out the fraud, waste, and abuse. Just like align us the way you want any regular government entity to align. So if the president wants to go in this direction, the state's governors should be wanting to go in the same direction, or at least be incentivized to get along with each other. What happened during COVID was a complete switch of some of those incentives because there was a national emergency. We were at war with a virus. So I'm not criticizing that. But when the war's done, you've got to go back to peacetime funding and peacetime approaches. So what the One Big Beautiful Bill, which is now called the Working Families Tax Cut legislation, what that did was turn the clock back effectively to the way we were running Medicaid in 2020. So, for example, if the federal match is that the state pays a quarter and we put in 3/4 for every dollar of care that a Medicaid patients get, that's the deal, right? That's why the state should be caring about the cost and the state. But there are states where, for example, when expanded Medicaid, the state wasn't putting any money up. They had gamed the system with these different provider taxes and state-directed payments that shifted that match unfairly I wouldn't say unfairly, in a way that no longer incentivizes states to care about the spend as much as the federal government. And that's a dangerous thing when I'm paying the bill and you don't care. And so that's been now adjusted. And there was no money cut. We're putting $200 billion more dollars into the system. But there are other problems we have to address. The most important was work requirement. And if I can just spend 2 minutes on this topic because it's really important. The purpose of health care is not just to get you out of the hospital alive. It's to get you to thrive, to flourish, to live the life that you were given, that's yours, to own it. And so healthy people get to be on the playing field of life at a different level. We want that for all Americans. If you're an able-bodied person on Medicaid, on average, you're spending 6.1 hours on the sofa watching television or hanging out a day. That's been studied. And so it turns out people don't want to do that. People don't want to just stay at home. They actually do want to go work, but because of this bizarre compensation, almost bribe for you to stay home by giving you free health insurance, you incentivize people not to enter the workforce. So President Clinton, in the late 90s, created a work requirement in the system that he was changing the temporary assistance for needy families, and he brought welfare reform in that capacity. President Obama said that work requirements are fundamental to any social safety net program. President Biden said that. All Republican presidents have said that. The question is, can you do it effectively? Or is it really just a ploy to get people off Medicaid and pretend you're checking work requirement, but you're just sabotaging their ability to get care? We do not want the latter. In fact, we're making major strides to try to address what we think is important, which is to allow people easily, effortlessly, to, on their phone, be able to tell me where you work. I can quickly figure out who your payroll provider is. Let me ask them how much you've worked. And if you haven't worked the 18 hours a week that we're asking you to work, here's a bunch of things you can do. We want to connect you to the employment office. You can go get education. You can go volunteer. We give you a lot of things that you can do, not just working, community engagement, so you can show up in the lives of people you care about in your community. We want that to be the norm. We know what happens in countries where that's not the case. Right. You get generational poverty, where no one you've ever known has had a job. And so it's no longer part of your culture. I also think that if we handle this correctly, we'll do something else really important, which is you get people that we have twice as many jobs in America now as people willing to do them. So you get more people off the sidelines into the workforce. And, maybe you're an Uber driver making, $18 or 18 hours of work a week. Maybe you get you a job at a trucking company because you can drive. And now you're working full time. And now that you begin to graduate from that and become more senior, and now you're in the workforce, you're making real money, you have commercial health insurance. It's where you want to take the country.
Yeah. Great. This whole issue of Medicaid and rural health care is a real challenge, the quality of rural health care and just access to care. Little trivia tidbit that folks in this room may know, that Georgia is the largest state geographically east of the Mississippi. So we've got a huge rural population, and the challenges there are not unlike others around the country. So providers in rural areas have read, and it's been described as reductions in Medicaid spending. And the Rural Health Transformations Program, which I applaud and I think has great promise, I want you to talk a little bit about that, understanding that we've seen these kinds of programs before, and oftentimes they just kind of fade away and don't have any real lasting effect. Help us understand why the Rural Health Transformations Program is what needs to be done and how that can help improve the quality of healthcare and access to healthcare in rural America.
Well, Tom, there's a lot of concern about rural healthcare. There was when you were secretary. There still continues to be, even without the new bill, a lot of appropriate concern when 40% of rural hospitals are reporting financial struggles. 150 hospitals are shut down in the last 15 years. We've got half the occupancy of urban hospitals in rural hospitals. But we also have a healthcare crisis in rural America. We have an incidence of chronic illness across the board that's 20% higher than in urban areas, much higher rates of suicide, maternal mortality rate. The average life expectancy in rural America is 3 years shorter than that in urban America. So we have got to do better. Your zip code should not predict your mortality rate. That stated, some of the problems are structural. We have a lot of hospitals that were built 50 years ago. They had 100 beds in them. They're now at 10-bed capacity. They've downsized. but they have a census of one patient. And people in the town don't stop at that hospital. They go by that hospital to the one that's 30 miles away that they trust more. And so we've got to restructure the system. Now, there was a lot of concern about how much money was coming out of rural hospitals with the One Big Beautiful Bill. Let me just give you the numbers, because it's shockingly low how much Medicaid puts into rural health care. Only about 7% of Medicaid dollars pay for rural health care. That's about $19 billion a year. It turns out when Medicaid spends more money, the money stays in the big cities, or at least the areas that are connected to the capital. People who have lobbying connections, they just have the ability, they know the game.
But that money in those communities is vital.
Yes, but the 7% that goes to rural America is not keeping it going.
Right.
So that's, again, $19 billion. Let's do the math together. $19 billion today, and we're failing. So we're going to put an extra $10 billion a year into the system for 5 years. That's a 50% plus increase across the country. Our hope is not to pay the bills, because that's not sustainable, because it's not working. It's to transform the system. There are folks in this room who are part of this solution. I see Kajar's name written in a few places. We've talked to them. That's a good example. What if the big trusted hospitals, the Kajars of the world, the Emorys of the world, there where my dad trained, what if they start adopting rural hospitals, and we provide at the federal level some support for that process? So you have a little OB clinic, south of Athens, and they're doing 2 deliveries a week. They're not going to be great at delivering babies with 2 babies a week,
right.
But it's better than 0 babies. But what if they got adopted by Emory, and now you have the big OB center here, working with them, culturally connecting, understanding their strengths and weaknesses, appreciating where the gaps might be, so together they can provide better maternal care to moms delivering babies. Yeah. It's that kind of approach. We have ideas around workforce development. We have, in many parts of the country, massive nursing shortages. We could train a lot of nurses, LPNs, at community colleges. We just have to get more teachers in the community colleges. And so that's a great place to put some of these resources. In fact, we're going to do that anyway, because it turns out that when nursing homes pay fines, we aggregate that money into a fund, and we have to spend it back in to make nursing homes better. We now have a couple $100 million. So we want to partner with states. We own part of that money. The states own part of it. I'm meeting with Governor Kemp later this afternoon. I'm going to say, match us. I'll put money up, you put money up. Let's go in and train thousands and thousands of nurses and get them into the communities. And nurses stay in their local communities. So if a nurse trains at a local community college in a rural area, she's more likely to stay put. She might work in a nursing home there, or help that hospital with a census of 1 become a census of 3. And it's that little edge that makes us successful. Yeah. And then we have another big idea, which plays to many of you, which is, where's the role of technology? In the bill, which is 25 pages, that part of the bill is 25 pages. I encourage you to read it. Page 475, right? But I'll tell you, there's 10 criteria that you have to try to satisfy 3 of them. 10 criteria total, 3 have to be satisfied. And guess what? There are 3 that are technology-based. It's the only place that is like that. All the other ones are spread out. But just technology alone will hit 3. But we have to be able to figure out affordable EMRs for rural hospitals, better tracking of patients, allowing patients who are in trouble to get appropriate telemedicine. There's so much technology can do, especially in behavioral health, that we have not been able to capitalize on because we didn't have the capital, didn't have the resources. With $10 billion a year, every year for 5 years, there is no excuse. And here's the reason it's a space race. I want all the states trying to do the best they can, because every year we get to reallocate the money. So we're getting the applications. They came out Monday. We're getting back the first week of November, and we're giving all the money away by the end of the year. It's fast. But the reason for that is that the president and Congress wanted this money out the door in the pockets of the governors so they can spend it quickly. And they should feel pressure to spend it wisely. And we want all the states talking to each other about best practices, because rural health care in the North Shore, North Slope of Alaska, which is frozen in for 6 months a year, is very different from South Georgia.
That's right. That's exactly right. Workforce challenges are huge, and so many of these folks know that. They're trying to care for folks around our state and our region, and the challenges are massive. 1/3 of the nurses in this country who work currently are over the age of 50. Half of the docs in this country are over the age of 55 that are still practicing. So the numbers are stark. You mentioned technology being something that can be helpful. Share a little more about how technology can be helpful for both access and quality of care, or even productivity in the health arena.
If you think about almost anything you do in life, over the last 20 years has changed dramatically because of technology. You stream content. The content streamer tells you what you probably like based on what you did. All banking has changed. Travel has changed. Passports. I remember, most of you remember, you get a picture at the drugstore, send it off with your passport, and hopefully you get it back in 6 months. You can today get a passport in 2 weeks. 2 weeks. And the woman who built that system, Amy Gleason, is actually running the digital transformation for us in healthcare. She's the one doing the work requirement effort, for example. So we believe that by using technology wisely, we can dramatically transform not just the empowerment of patients, but the way that doctors themselves practice medicine. And I say this having looked at and played with agentic AI tools that are shockingly good. You can't even tell when you're interacting with these devices that it's not a real person. But the point is not to replace a doctor or a nurse. The point is to augment their ability to care, to do things that historically should have been done. But let me be very blunt about the reality that we've been trying to do this for at least 10 years. Right? You were there. So why hasn't it worked? Because there are people who make a lot of money when it doesn't work. And so they toll the system. They put up gates and blockages, or they just don't want to do it because it's a hassle, or they're not paid enough to do it. So all of a sudden, this system sort of slows to a complete sludge speed, and then eventually stops. And we've made it very, very clear, and the president has an executive order on this, and we've already gotten a fair amount of agreement on the reality that we're just not going to tolerate that anymore. It's just failure is not an option. We can't afford it financially, and we definitely can't afford it morally. It's reprehensible we haven't been able to catch up to the rest of the country and their technological advancements. So on the 30th of July, Amy Gleason, who I mentioned earlier, the Secretary Kennedy, myself, met with the president at a public event where 60 companies signed a pledge to commit to interoperability and transparency and working with us to fix the healthcare IT challenges. ShareCare, who's here somewhere, put your hands up if you're here. There's one, there they are. Jeff and Dawn and the rest of their team, but there were other Georgia companies as well that were, and now we have over 200 companies that have signed up. And I actually this afternoon they're presenting, which is why I bring them in. Please go, pay attention to their experience. Don't judge it from me. Talk to the people who are the actual customers, folks who are trying to work with government, and then join us. Go to the CMS website and pledge to be part of the interoperability solution. We will within a year, be able to give patients their medical records because we'll know who they are and they'll be able to adjudicate that they own their records, they trust that it's a safe platform and they can give it to people who they have it. We'll be able to get doctors within their workflow to be able to get compensated for what they're doing. Why do we need prior authorization? Why do we even need coding for severity of illness? Severity of illness is one of those classic stories. It makes perfect sense in abstract, right? Tell me how sick the patient is, I'll pay you more if they're sicker. Turns out that the severity coding predicts maybe 15% of how much sicker a patient might be than we would predict normally. It doesn't help that much. It takes an inordinate amount of time. Prior authorization, same thing. Prior authorization is 12 hours a week of a doctor's time to try to figure out how to work through the morass of the insurance company, the gauntlet that's created. And the insurance company, they spend 12 hours of some professional's time a week to try to figure out if the doctor's cheating them. What if we just had a system, which is now being done, that actually allows the insurance companies to figure out a better path and then penalizes them if they don't do it? Well, that's what I want to do with technology. And this is, to me, and we had a piece, Marty McCary, who's, by the way, the head of FDA and the head of NIH, the three people that Bobby, the Secretary Kennedy, put in place. We are very close friends. We were before. We work very closely together. So we had an op-ed in the Wall Street Journal a few weeks ago about the power to convene. And what we're trying to do across the board is say, listen, we have the regulatory authority, as you know. We can pass laws, but it's clunky. It's like taking a sledgehammer or bat to these problems. Industry has nimble solutions. You know the business better than anybody. Fix the problem. We went to the insurance industry and we said, you guys, you already know you're having an issue here. The horrible shootings that we've witnessed over the last several months have been, just shocking. But the murder of the United Healthcare executive in New York in December was chilling because people celebrated his assailant. That's how bad a problem this is. So go fix it. So God bless these guys, the biggest insurance companies representing more than 80% of the public. went out there and they came back to us with a mechanism to address prior authorization. By the end of this year, it's going to be better. By the end of next year, it should be done, and adjudication can be done almost immediately. You know why they're struggling? Doctors don't respond with digital tools. They respond with paper because they don't trust the insurance companies. So if you can get the doctors and the insurance companies on this one issue to get along and exchange digital content, it would be like a credit card. You put your credit card in to get a coffee. You don't wait around for 3 weeks to find out if you're approved, right? The banks work behind the scenes. People trust the system. You put the card in. They know what you're paying. You know that you have money in the bank. What does money in the bank mean? Banks all decide they know what that means, and then they adjudicate it and they pay it. We could do the same thing. We could pay doctors as they take care of patients in return for getting all that data and hearing back from us ideas that might make the care better and information that the patient could listen to as well.
In real time.
Yeah, and then pay them, obviously, because that makes the war go round.
In real time, decrease that AR. Health Connect South, which, as you can see, is a large entity, this summit that occurs, and the whole mission of Health Connect South is to provide a forum for collaboration in healthcare. Healthcare, as you know, is extremely siloed. You've got folks all across, you've got the cream of folks all across the spectrum, whether it's nurses or docs or hospitals or health systems or entrepreneurs or other innovators, business, academia, insurance, everybody here. So how would you advise them, these leaders here today, to move in the direction of collaboration in healthcare?
I promised you before we walked out that I learned this in television, make it the first thing you say and the last thing you say. We are open for business. We want to hear from you in a lot of different ways. We want some of your best people to come work for us. I'm here recruiting. We want to hear ideas from you, ideally through the people who are in the area you're already in, because they know a ton about it already. And you might be surprised by how much they appreciate about what you think would help, but what they don't know is the reasons you're not helping us. What are the real obstacles that are slowing you down and your business is down? And I'll give you a concrete example. We have a dream that there's going to be an app ecosystem. Literally people going in and getting, just trach me right here, cut right there.
Yeah, we can do that. Yeah. You don't want an orthopod to do that.
No, I trust an orthopod.
Yeah. You got a water?
Yeah, toss it up to Noah. He's got a good arm. This is hand off.
Hand off.
He's not going to throw it at me.
Thank you very much. Appreciate it.
So the real goal here, let me finish the statement first, is if we can get people to, in an app, Google Play or Apple Store, put in credentialed apps that we know can help people with their diabetes, hypertension, their depression, their substance use disorder, and then put money into the system in a way that allows them to serve the customers, which is the American people. It's going to work better than if we're the customer. If the government's the customer and someone's building a federated database out, and all they want to do is sell it to us, then we're not serving the American people. And you're going to end up with this system similar to other ones we've built, where billions of dollars get spent from my coffers, your money, right, tax dollars, that pay for things that the people don't want. So we need people who have consumer-facing businesses, doctor-facing businesses, understand accounts receivable and financial management of these processes. Don't just use AI to churn up bills. Use AI to adjudicate the best quality care and then get paid more for doing that. Use avatars and with AI to connect with people in ways that we can't continue to interact with them because we can't talk to the patient every day. Yeah. Meet them where they are. Even the basic advice you might give someone about what time of the day to go walk is better offered when we know the person is more susceptible to doing what you're recommending, which might not be in the doctor's office. And so all that should work. We're committing to two things right now. We're committing that we will build a system so I know exactly who you are. And with a variety of different techniques, ID me, clearly, with a bunch of different ideas of how to do this, and we've already working with these companies, we're going to create a very, very simple, straightforward, trustworthy way for the consumer to say, it's me, you know it's me, give me the data. Because it's your data, you paid for it, right? And then the second thing we're committing to do is a provider directory. End the bickering about who's where, when, practicing. This is the directory in America for who's practicing where and in what hospitals. With those two things, we can do everything from helping with brokering Medicare Advantage and ACA and with a bunch of other things, all the way through to folks with diabetes who are depressed and happen to be African American. Like, what's the app that works for them? Most likely. And then we would compensate the system for results. We're not going to pay for churn. We don't need to know how many people are on your site. Did you actually get outcomes? But I was on your side. I sat there for most of my life in the private sector, starting businesses, involved in technology in different ways. I know how you think about the pathway to profitability, how it changes your valuations when it's not clear, and uncertainty is death to many of you. This is the time to jump in the water.
Mm-hmm. Thank you. In addition to doing all those wonderful things that you did, you also took care of patients. And one of the things that I was so heartened by with this new administration that came in is the number of physicians that they've got leading these agencies, and you're at the top of that heap. And so we can't thank you enough for coming today, for your responsiveness. The message that I hear is open for business. So please avail yourself of the opportunity to communicate with CMS and with HHS. Our time has come to an end, and I want you all to please join me in thanking Dr. Oz for joining us today.
God bless you. Thank you very much, Tom.
God bless. God bless you. Great job. Great job.